start with talking about articular cartilage, focusing on imaging assessment, a little bit of the state-of-the-art, what we have available right now to assess articular cartilage everywhere in the body, and we'll focus, of course, on the magnetic resonance imaging, which we call MRI, assessment of cartilage, focusing on its morphologic assessment as well as its compositional assessment. And if we have some time at the end, we can talk about other imaging techniques such as ultrasound and CT arthrography. So let's start with magnetic resonance imaging. You may all know this is a tomographic technique with no radiation whatsoever involved. It has a multi-planar capability, meaning that we can acquire images in different planes, and we'll see that in the presentation. MRI is superior to any other imaging method when it comes to tissue contrast. It has superior tissue contrast compared to other techniques, providing high spatial resolution images to assess not only cartilage but different structures within the joints, and it allows as well, as I just said, direct visualization of all joint tissues and not only cartilage. And this is very important as well to assess or to evaluate the articular cartilage. So we start about the morphologic assessment. This is a very busy slide, so you can see that we have a bunch of different techniques available on MRI to assess not only cartilage but other joint structures. So what we call here the routine techniques, it's what we use on clinical basis to assess any joint, not specifically cartilage, and we have different techniques and different contrast tissues like T1, T2, proton density, intermediate weight and stir, and the column on your right refers to additional techniques which are three-dimensional techniques. Unfortunately, those techniques did not replace yet the assessment of the whole joint when we compare it to the routine techniques. We will talk about some of them. I'm not going into details for each technique. I recommend you something we published a few years ago in this radiologic journal, which is radiographics. So there's a table there that explains you details about characteristics of each technique available to assess the articular cartilage, including its strengths, its drawbacks, as well as some useful information about the assessment of other joint tissues other than the articular cartilage. So what about the normal appearance of articular cartilage when we perform MRI? And this is something that you all have to be aware of. It's very important to know how to manipulate contrast between the different tissues and structures within the joint. If we can do that using MRI, we can find a good sequence, a good technique to assess the articular cartilage. So I'm putting, it's the same knee, same slices, same axial slices, assessing the cartilage of the patella. And here you can see the sequence is a T2 weighted sequence. It has a very long, we have some parameters on those sequences, and the time of echo is one of those parameters. On T2 sequences, we have a fairly high times of echoes, and when we do that, what happens is that we lose a lot of the signal from cartilage. And you can see here, the cartilage is black all the way. It's very black. The signal is very low. It's important that because we lose signal, so we cannot really assess what's going on within the cartilage intrasubstantially. But on the other hand, it's important because we have a very good contrast between the articular cartilage and the synovial fluid. You can see here, synovial fluid is really bright. The signal is very high, and signal from cartilage is very low. So we have an excellent contrast between these two structures, and it will help us to detect superficial cartilage damage. This is very important. You can see this other technique here. We have more signal within the cartilage. This is a gradient echo we call sequence. It has some drawbacks, some problems when assessing cartilage, and we'll discuss that later on. But as you can see in the sequence, we have very nice contrast between the signal of cartilage with an intermediate signal intensity. We see here the subchondral bone cortex having a very low signal intensity, and the synovial fluid here with a very high signal intensity. So we have great contrast between cartilage, subchondral bone cortex, and the synovial fluid, and that's perfect to assess the articular cartilage. You can see this other sequence here as well. Here we use fat suppression. We suppress the signal of fat. This is an intermediate weighted sequence, meaning that the time of echo that I told you about before, it's not too high, so it's between 35 to 6 milliseconds, and it's optimal to preserve signal from cartilage, keeping a great contrast between the articular cartilage and the synovial fluid, which is really bright. You can see here high signal intensity within the synovial joint, and the subchondral bone is black, especially because we suppress the signal of the fat. So this is an ideal sequence to perform routinely when we are assessing the articular cartilage. Some other examples of the normal appearance of the articular cartilage using different techniques. So on your left, examples, sagittal slices of the T1 weighted sequence. We preserve a lot from the signal of cartilage because T1 sequences have a very short time of echo. So this is optimal to preserve signal from cartilage. But the problem here is the synovial fluid will have pretty much the same signal in cartilage. So we don't have enough contrast between both structures, and this is a problem, and we'll show some examples later. And this sequence here is the intermediate weighted fat suppressed sequence that I showed you before in the patella. This is, in my opinion, and in the opinion of many other musculoskeletal radiologists, it's one of the best sequences to examine not only cartilage but the whole joint. And here I show you an example of a gradient echo sequence. We don't really have to know which sequence we're dealing. Is this a gradient echo, spin echo, whatsoever? When you see an image, it's important to see that we have good contrast between different structures. So we can see in these two sequences, we have excellent contrast between cartilage, the synovial fluid, and the subchondral bone. And that's okay to evaluate the morphology of cartilage. So now I give you an example, some examples of cartilage pathology regarding morphology. So this is the same sagittal slice, the same knee, using different techniques. So on your left, the T1 and the middle T2 sequence, weighted sequence, and the intermediate weighted fat suppressed sequence on your right. So you can see here, because we don't have enough contrast between the synovial fluid and the articular cartilage when using T1 sequences, it's difficult to find a lesion here, a chondral defect here, because we don't have enough contrast. On T2 and on intermediate weighted sequence, on the other hand, we have excellent contrast between the articular cartilage and the synovial fluid. And that's why it's easier to see here this focal chondral defect in the central region of the medial femoral condyle. Note that on T2 weighted sequences, the signal of cartilage, again, is extremely low. We lose a lot of signal because the time of echo is too long. And on intermediate weighted sequence, the time of echo is not that long, so we preserve more the signal from cartilage. Here another example how it's important to know how to manipulate contrast between different tissues when assessing, especially in this case, the articular cartilage. So it's the same slice, the same axis slice, the same knee, using two different techniques. So this is a gradient echo technique, and this has some issues regarding detection of very focal chondral pathology, and we'll discuss that later. You can see here maybe we have some problem going on in cartilage, where the arrows are pointing out in this sequence. But we don't have enough contrast between synovial fluid and the articular cartilage. And it's a problem. We still have on such sequences some magnetic susceptibility artifacts that it's giving us some trouble, some problems to detect this focal point. So what we can do, because we think this is a superficial pathology of cartilage, we can use a sequence that we increase the time of echo and we decrease the signal from cartilage while maintaining the signal of synovial fluid very high. So we have a very nice contrast between these two structures, between two tissues, and we see here very clearly this focal chondral fissuring or delamination in the patella. Some of the arthroscopic classifications of chondromalacia were applied to MRI not that recently, but in some publications. So this work here, published in Radiology in 2006, they tried to apply the modified outer bridge classification of chondromalacia using MRI, using especially stir sequences. Sometimes it's difficult to apply such grades, especially the grade 1. Grade 1 is a very early degeneration of cartilage. We see some softening and swelling during arthroscopy. Oh, thank you so much. We see some softening and swelling of cartilage when probing the cartilage during surgery. And cartilage has to be very stiff when it's normal. And for grade 1, what we can see on MRI is some signal changes within the substance of cartilage. Intrasubstance signal changes. It might be low signal changes or high signal changes going on within the cartilage. But we are not very good on MRI to detect grade 1 chondromalacia, and we'll discuss about that later. Grade 2, outer bridge, is a very focal chondral defect, less than 1 inch, and it's a partial thickness focal defect, like in this example. Grade 3, as you can see here. Hello? Oh, sorry for that. Grade 3, as you can see here, it's a wider partial thickness defect, more than 1 inch, or you can have a very small fissuring going directly through the subchondral bone. You can call it grade 3. And when you have wide exposure of subchondral bone, we're talking about grade 4 in the outer bridge classification. The noise classification is another one that many papers try to attempt to perform such classification using MRI. And here's some examples to show you. Grade 1, it's very similar to the outer bridge. Some swelling or softening of cartilage, and we may see signal changes within the cartilage and as well as thickening of cartilage. Grade 2A refers to partial thickness pathology taking less than 50% of the thickness, and grade 2B, partial thickness defects taking more than 50% of thickness. And grade 3, when we have exposures of chondral bone, as you see in this example. So what about the diagnostic performance of MRI when assessing cartilage morphology? And I'm talking about assessment on 3 Tesla to show you that we are really bad to detect grade 1 chondromalacia. We're not good at all. Sensitivities reported in the literature goes up to 25% only. And this is very bad. This is not good at all. And when we talk about real defects going on in cartilage, like grade 2 or grade 2A or plus in both classifications, outer bridge and noise, we are better. And of course, for higher grades of cartilage pathology, we're even better when using MRI. Specificities are not there for all grades. And when we compare what is available in the literature, the 3 Tesla with 1.5 Tesla, which is widely available, way more than the 3 Tesla, we don't have a lot of difference regarding detection of cartilage pathology. We only have a small increase of specificity. We have fairly similar sensitivity and similar inter-observer agreement when compared both methods. So we can use 1.5 or 3 Tesla to detect cartilage pathology. Of course, we have to take into account other parameters of software and hardware when talking about assessment. This is something I brought to you to show that we see that a lot. It's very often, it's a very common finding when performing MRI of the knee. This black linear signal change within the substance of cartilage. It's often seen in the trochlear sulcus, as you see in this example. This is the small signal, but sometimes we see these low signal changes within the cartilage in other areas, and they're not necessarily linear. And most of the times we don't know what to do about it, what we're going to report, what we're going to say in the report. Is this pathology? Is this variant? Is this some calcification going on? This is very difficult. Sometimes we can see, like in this example, this is the same knee, an axial view and sagittal view. We have some subchondral bone marrow changes, like this subchondral bone marrow edema-like change, just adjacent to that low signal intensity. And when I see that, I am more confident to call for cartilage pathology in those cases. But when we don't see that, it's a problem. And this was published, 2 papers recently published in Skeletal Radiology, which is the journal presented by Dr. Crema. Disappearance. So we find it, we don't know what it is, and they did perform arthroscopy in some of the patients, and they found a deep fissuring of cartilage. And that's a problem. In this case, they don't even have any subchondral bone marrow change involved. So this is very tricky. I often describe this in the report, saying that it might represent cartilage pathology or cartilage fissuring, because we don't know, really, we cannot be sure what's going on. Often this is nothing. The surgeon goes through arthroscopy and he cannot find anything. Another example of this black, very low signal changes within the substance of cartilage, we see one here in the central posterior region of the lateral tibial plateau, and we see another here more linear. This is more diffuse, and this is more linear in the patella. No subchondral bone marrow changes whatsoever. Maybe a small one here in the patella. And we have correlation with CT arthrography, and you see that we have a deep fissure of cartilage here, and we have another deep fissuring of cartilage here. So this was pathology. This is very tricky, it's very hard to call when we're reporting those. Let's talk about a little bit the gradient recall echo sequences. Most of dedicated techniques for cartilage we have on MRI are actually gradient recall echo sequences, what we call GRE type sequences. This is the main tool for quantitative assessment of cartilage when we segment cartilage to evaluate the whole thickness or the whole volume of cartilage in a joint. And it has a potential drawback, which means a problem. It's for the detection of focal contour defects. And this is often because we're not manipulating contrast properly when using the sequences, especially dealing with the flip angle of the sequence, and some magnetic susceptibility inherent to these techniques might also give us some trouble when detecting some focal defects. So I showed an example here how we can manipulate contrast by changing the flip angle using the sequences. So the example above, you can see here. So let's do like this. So you can see here in this example above. So this is a routine sequence. This is a routine sequence we use clinically. You can see here, there's a fairly thinning of cartilage of the patella, but this area, we can see the synovial fluid very bright go directly to the subchondral bone. This is a full thickness defect with some subchondral marrow changes associated here. I'm sorry for that. And we perform in the same slice, exactly the same slice, a GRE type sequence, a gradient echo sequence, with a flip angle of 20. This is a very low flip angle to evaluate articular cartilage because we have some T1 contamination in the sequence. So the signal of fluid will drop. And because the signal of fluid is not really extremely high, as you can see here, it's fairly similar to the signal of cartilage. We cannot see that full thickness defect. And problem. When we increase the flip angle of such sequence, we go to 90 degrees. You can see here that we increase the signal of fluid, and now we can see that's a full thickness cartilage defect here going on. So it's very important to know how to manipulate contrast here. And such sequences are often used for cartilage segmentation and morphometry. This is, of course, used for research purposes. It's not for clinical purposes, where we can reproduce even diagrams showing you the whole volume and the whole thickness of cartilage within the joint. We have also semi-quantitative assessment, and this is also for research purposes. This is not for clinical purposes, where we have different grades of cartilage pathology. When we evaluate, this is more visual than quantitative. That's why we call it semi-quantitative. We divide the joint in several regions, and we try to score cartilage using this very complex scoring system. And this is important for us in clinical research because we can depict very small changes over time when we are following patients for natural history studies or for interventional studies, like in this case. This is a very rare case of spontaneous cartilage repair. We can see here. So posteriorly, we see in the lateral femoral condyle, we see a chondral defect, clearly depicting the sequence. At 6 months follow-up, we cannot see it well anymore. Maybe it's going better, we're not sure. But at 12 months, we see that it almost completely disappeared. So this is a rare case of spontaneous cartilage repair. And we have to be aware that it's rare, and we could depict that because we have the semi-quantitative scoring systems available. Talking now about this fairly recent technique introduced in the literature, which is the three-dimensional fast-spinacal or turbospinacal imaging. As I told you, most dedicated cartilage techniques we have on MRI, they are gradient echo techniques, and the problem is that these gradient echo techniques, they cannot replace routine techniques we use for daily clinical purposes, because those sequences, they are good for cartilage, but they are not good to assess other tissues in the joint, like fibrocartilage, like ligaments, like subchondral bone. They're not good at all. So the advantage of three-dimensional fast spinacal technique is because it has spinacal contrast. So we can evaluate not only cartilage, but also all other joint tissues, including the meniscus, including ligaments, subchondral bone, etc. And it's a 3D, it's a volumetric acquisition, and we avoid a lot of partial volume effect. And it was shown in the literature to have similar diagnostic performance and excellent agreement when compared to routine sequences. So I show you what it is. Actually, this is a 3D fast spinacal, turbospinacal, with intermediate weighted and spare acquisition. This was acquired in sagittal plane with 0.6 millimeters. It's very thin. It's extremely thin. So we acquired that, and with the source images, we can reformat in every plane we want, like axial, sagittal, coronal. If you want obliques, you can do it. You can do whatever you want. And this is fast spinacal contrast, which is great. So this has a huge potential to replace routine sequence, and this will be faster. We acquired that sequence in a 1.5 Tesla magnet within 5 minutes. Some examples to show you. So I'm always putting on your left routine sequence, two-dimensional sequence, and a 3D turbospinacal sequence to show you. We can see here some very mild focal chondral defect, very superficial one, but it's really tough to call in this routine sequence. But we are more comfortable to call this very small focal chondral defect using the volumetric fast spinacal sequence, as you can see here. This is another example to show you that both techniques, 2D and 3D techniques, they did show this deep fissuring of cartilage here and here in the medial facet of the trochlea. And this is another example, and this is a scary one because in the routine sequence, very honestly, I don't see anything. Cartilage will be normal in the report. And when we see the 3D, we see that we have mild thinning, and the surface, the contour surface is irregular, and so we have some very initial cartilage pathology going on in the medial compartment, and we missed that from the 2D acquisition. I will talk briefly about compositional assessment. This is very specific. I don't want to blow your minds about this very specific technique. Compositional MRI, actually, it's important to detect alterations within the cartilage matrix before we can see contour defects morphologically. So we see cartilage, we think it's fine. There's no defect whatsoever. But then we apply such compositional techniques and we see that within the cartilage, in the cartilage, it has some problems going on, especially regarding early degeneration. And what we're evaluating here is the collagen content and its relationship with the water content within the matrix, as well as the proteoglycan content of cartilage, what we're going to call GAG. It's simpler to call GAG. It's the proteoglycan content of cartilage. Those are special techniques that require specialized software. Some of them are not applicable in clinical scanners. It needs segmentation, so it's very time consuming and it's very difficult to implement in clinical practice. This is often used for clinical research nowadays and less for clinical practice. And the prediction of incidence and progression of cartilage deterioration or loss over time, we don't have to date strong evidence showing that this very early degenerative changes that we find using compositional techniques, it's not leading to anything like loss of cartilage or deterioration of the joint in the long term. We don't have such evidence. We have a bunch of techniques for compositional assessment. I will discuss the main ones, not all of them. So the T2 mapping, you probably heard about it. This is a technique that's capable to detect the very early disruption of the collagen matrix, and when it happens within the matrix, the relationship between the collagen and water, we're going to have a breakout of collagen, and we're going to have more water molecules free within the cartilage matrix. And when we increase the content of free water in the cartilage matrix, we will increase the T2 values of cartilage in that side, indicating that we have a breakout of collagen content within the matrix. So just some information for you to know. T2 values are higher in painful knees compared to knees without pain. No strong evidence about that. It's very preliminary studies showing that. But what we know is that no linear relationship whatsoever between T2 values and development of OA. So we see this very early degeneration within the cartilage. This is not leading to OA so far. We don't know. It might be, but we need more studies to do that. There was a linear relationship between these T2 values and cartilage defects, but it was used in some scores, some issues in that paper. Something you have to know when applying compositional techniques, not only T2 mapping, but all compositional techniques, is that physical activity may change the T2 values of cartilage. Especially, it might increase the T2 values, and this will simulate early cartilage degeneration. So when a patient will come to the clinic, to the facility, to do MRI, and you want to do T2 maps, if you know that the patient, he or she did climb, stairs for 10 floors, and you put him in the machine, it's going to be alterations all the way. So we cannot do that. We have to prepare the patient. We have to put the patient at rest before applying such techniques. And there's this very recent paper published in Radiology 1 month ago showing that compared to arthroscopy, T2 mapping helps to improved detection of grade 1 chondromalacia, which we're very bad when using morphologic assessment of cartilage, I told you, but it seems that T2 maps might impact on the detection of grade 1 chondromalacia. A small example to show you how it looks like. We have softwares to generate a color map, which is easier for us to define what is pathology and what is not pathology. So theoretically, higher values of T2, which is in the color scale, you're going to see it's more for the yellow, orange, and red colors. So these would represent early cartilage degeneration. So breakout of the collagen matrix. So these areas here in yellow, as you can see in the cartilage, and maybe some of these very superficial ones, have to be careful when it's very superficial. It might be the synovial fluid, some contamination with the synovial fluid because it has a very high T2 value. So you have to be extremely careful when interpreting such maps. Another example is being used, especially for research purposes, to evaluate, to follow up subjects with surgical cartilage repair. And this is an example. This is a routine sequence show baseline, a huge chondral defect, a huge traumatic chondral defect in the femoral condyle. And they did some autologous chondrocyte transplantation in this case. And you can see here some cartilage hypertrophy going on in this region, so more cartilage than we need. Some bone marrow edema-like changes in the subchondral bone, and when we generate T2 map color, you see that with the colors that it's fairly heterogeneous. Cartilage is very heterogeneous with areas of high T2s compared with this normal area posteriorly. You can see the colors are completely different and it's more homogeneous. The Jamrick is another compositional technique. It's a synonym for, let's say, abbreviation for delayed gadolinium enhanced MRI of cartilage. And actually, this is evaluating the proteoglycan content, the GAG content. So we inject gadolinium, we exercise the joint for 10 to 15 minutes, and then we wait 90 minutes, so 1 hour and a half, to wait gadolinium to diffuse within the cartilage, and then we do the acquisition. So it's really time consuming. We need intravenous contrast administration, and this gadolinium, because it's charged negatively, this will occupy areas within the matrix where the proteoglycan content is low, because GAG is also negatively charged. So where we see this gadolinium entering cartilage is areas of early degeneration, of low proteoglycan content. It was shown a relationship between the Jamrick and incident radiographic osteoarthritis, but this is a paper with, I can say, several limitations. I just put it here for our information. We did some work with the Jamrick recently with our group in Boston, and we showed that we can monitor the GAG content within the cartilage regarding the presence or not of meniscal pathology. And I show an example that will be easier to understand. And we also did some work on the Jamrick showing that worsening of the Jamrick in pre-OA, in very early OA radiographic osteoarthritis, was associated with thickening of the articular cartilage. And we think that what we see in the very early stage of degeneration, this softening, swelling of cartilage, was associated with depletion of the negatively charged proteoglycan content. Again, to show you that all these compositional techniques might be effective for physical activity, so be careful with physical activity. It does not mean that the cartilage is degenerating. This is a young athlete, so he ran a marathon. So before a marathon, you see how the general, how the colors appear. The cartilage is homogeneous with, I would say, intermediate degenerate values. And you can see 1 day after marathon, and even 1 week after marathon, the cartilage becomes heterogeneous with lots of so-called lesions, which represented by lower degenerative indices. You can see here in the color scale, those red dots would represent cartilage degeneration, but we know in this case it's not cartilage degeneration. This was associated with the exercise of the base. So be careful with physical activity when performing such techniques. And this is an example to show you how we can monitor the gag content used in the Jamric regarding the presence of meniscal pathology. So you can see here on your left an example of a horizontal meniscal tear, typical horizontal meniscal tear, and you see at baseline how the Jamric was, the colors. You can see most of the colors were yellow or blue, and you can see here in the scale, those represent higher degenerate indices, so not a lot of degeneration. And 1 year later, look what happened to the central region of the medial femoral condyle. It turned to red with lower degenerate values, meaning lower gag content. So the cartilage started to degenerate more. So we could monitor the gag content regarding the presence of meniscal pathology. And to end the MRI assessment, so there was a fairly new technique called T1 row. This is capable to monitor changes of collagen and gag content within the cartilage, but recent studies show that it's more associated with the proteoglycan content, which is even better because it's the really initial stage of degeneration. So when we have high T1 row values, we have less proteoglycan content. And this is better than the Jamric because we don't have to inject contrast, we don't have to wait 1 hour and a half, so it's not invasive. It takes about 6 to 8 minutes to acquire the sequence. And there is some data showing that T1 row is more sensitive than T2 mapping regarding early cartilage degeneration. Could be also applied to the menisci, and it was shown to monitor cartilage matrix degeneration regarding the presence of bone marrow, subchondral bone marrow changes like BMLs. We don't have longitudinal studies showing that T1 row is predicting osteoarthritis or further degeneration of cartilage. We have to have some more work done until we can state that. Show you an example. So this is a knee without osteoarthritis on your left, and this is a knee with osteoarthritis on your right. And you see the colors are completely different. T1 row values are completely different. They are much higher along the medial femoral condyle, as you can see here in the color map, the values compared to this knee. Okay, I don't know what about the time. Yes? So I move on with other techniques to show you. I just prepared the MRI, which is the main part. So let's talk a bit about ultrasound. Ultrasound is being used to assess cartilage, which I personally don't think is a good idea. There is some data in the literature showing that it's okay. I will show you some facts, and then you decide yourselves what you think about ultrasound. So it allows visualization in multiple planes. It's a real-time exam and allows for dynamic assessment. This is, of course, an advantage compared to any other imaging method, especially compared to MRI and CT. There is no radiation involved and it's inexpensive. It's widely available. So this is the advantages of ultrasound. The problem of ultrasound in assessing cartilage is there is no visualization of the deep articular cartilage. We don't have very nice acoustic windows when we perform ultrasound of the joints. So we cannot really see what's going on in the whole cartilage, especially the very deep cartilage. So we're not looking the whole picture. That's the problem. Another problem is we have very low contrast between the cartilage and the synovial fluid. Both are hypoechoic. And that's the problem, because if we don't have contrast, how are we going to see very focal contour defects? And that's why it's reported in the literature that ultrasound has a very low negative predictive value. Meaning that you see the cartilage, you think it's normal, but you're not sure. It might be pathological. It might have pathology there, even though you see cartilage is normal. I showed a couple of examples. So on your left, normal knees, and on your right, knees with osteoarthritis, and this was defined by the radiographic assessment in these papers. So we see here the cartilage of the trochlea. It's beautiful. It's hypoechoic. We want to call that normal. Oh, this is normal cartilage. But the synovial fluid has exactly the same heterogeneity of the cartilage. So how we can call normal that? We cannot. It might be a very focal contour chondral defect in there that we're not seeing. On the other hand, when we see pathology, we can call it. Like in this example, I'm sure that here there's no cartilage whatsoever. So I can call for cartilage pathology using that method. That's no problem. So still useful. You can do it if you find pathology, great. But if you don't find pathology cartilage, there's a problem. We have to go for another method. CT arthrography, a couple of examples, is another technique. It's a tomographic as well, with high spatial resolution, even more higher than MRI. It has a multi-planar capability as well. It's more available in MR in a way, and it's excellent to depict very superficial cartilage damage. It's probably superior than MRI. We have very preliminary data in the literature, but we don't have a lot of work done in that regard to affirm that. The problem is, it's invasive. We have to inject contrast within the joint. It's highly invasive. It's not well validated for early intrasubstance changes, and the main problem, very poor assessment of other articular structures. So a couple of examples to show you that is good for cartilage morphology. MRI on your left and CT arthrography on the right. Both could detect this very focal chondral pathology. You see contrast going within the focal chondral defect, touching the subchondral bone in this case. This is another example to show you. Here we see it might be some pathology on MRI. Here as well, we see signal changes, some fibrillation of the superficial layer of cartilage, we're not sure. And when we see the arthrography, we're astonished by CT arthrography. Look at the size of this erosion, very deep erosion in the lateral occipital plateau. But when we come back here, I'm sorry for that, when we come back here, we see that the synovial fluid is not displaying high signal intensity. But it has some T1 contamination in the sequence. This was a problem of manipulation of contrast. And that's what I told you before. It's very important to know how to manipulate contrast. This is an example I already showed you.